Well, I'm usually not the person who makes it in time, yeah. But I think for those who made it in time, it's just a matter of respect to get started, and it's just an open conversation, so everyone can enter this. So first of all, a warm welcome, yeah, from us. Let us give you an opportunity to introduce ourselves. We are very, very excited to talk and discuss with you about the recent learnings from trials in the field of critical care nutrition. It's a hard topic and a bit disappointing, but we have as well something encouraging. But before we talk in more detail about that, let us introduce yourself. Jean-Charles, you want to start?
Okay, so thank you, Christian. My name is Jean-Charles Preiser. I'm from Brussels. I work in the Erasmus University Hospital. I'm intensivist and internist by training, with a strong interest for many years now on the metabolic and nutritional aspects of critical illness. I was also involved in studies on glycemic control, which was published about 15 years ago now, and so I'm involved in the field for a long time. And I'm happy to share this moderation with Christian. So just a final word. This is a round table, so please raise your hands.
Come closer.
If you have a question when we want us to discuss a topic. Don't hesitate to raise your hands.
Thank you.
We will be happy to discuss, to chat with you.
So, my name is Christian Stoppe. Yeah, I'm an anesthesiologist by training, but I shifted more in the field of critical care medicine. I spent 3 to 4 years in an institute of biochemistry. This is why I'm very much interested in the molecular mechanisms. I'm doing since more than 10 years a lot of clinical research, interventional clinical trials, international clinical trials, and although we may discuss some controversies, I'm still ongoing to do research in this area. So this could be already one take-home message. Otherwise, if all of this would be just disappointing, I would as well stop. Yeah. So therefore, it could be already one takeaway. Yes. So some housekeeping remarks, really. So if you have anything, any question, something is not easy for you, or you just want us to repeat something, please speak up. So let's first of all, why do we want to talk about that? I think it's clear we here all love nutrition, and we think it really matters. And we make really everyday nutrition-related decisions on our ICU with the overall attempt and aim to improve our patients' outcomes. And yeah, so the reason why we are here is that past trials challenged many of our old beliefs that high energy early is important, protein is important, micronutrients are very, very important. And I think we need a bit more differentiated approaches here. So please, when we talk about the different topics, and we have some suggestions about which we want to talk, very rough, it's like energy, proteins, then the route of feeding, micronutrients, and how to identify patients, phenotyping, for example. So how can this be done? What were potential mistakes? If I talk about mistakes, it's not like, hey, I want to blame about someone, but really like learnings. And yeah, so this is basically it. And the homework for all of us is to really keep in mind PICO, patients, intervention, comparator, outcome, and then you could talk about PICOT, trial design. So this is what you always have to think about. And we have learned as well that P and I are probably the most important things which we need to tackle, like the patient identification and the intervention. And with this, I just want to open the first round for questions. Are there any points which, in addition, you would like to discuss right now? Questions?
Please feel free.
Any suggestions? Please there. Yeah, Sebastian.
Thank you. Maybe sometimes before doing the PICO questions is when you want to make an intervention. And sometimes we're making interventions over things that we don't understand, over things that we can't see and we can't measure. We want to make interventions that last 7 days in the ICU, when in 7 days can happen a lot of things, and the patients are very different. We were speaking earlier. It's not the same. A patient that comes with a pneumonia, the inflammation is not the same. It's not the same surgery, a Hartmann surgery of after diverticulosis. It's not the same trauma. The inflammation is not the same. The switching of anabolisms to the catabolisms to anabolisms is not the same. So maybe that's why the PICO question over interventions is always not giving results, because we're trying to make the same intervention in patients that are not all the same.
So this is a very important comment. Thank you very much. I think that this is really related to the issue of individualization and the phenotype of the patient, which changes over the first week, of course. If the patient still needs an ICU care after 1 week, it means that the condition of the patient is still poor, but that we need to assess exactly. For instance, a topic that I'm quite familiar with is insulin resistant, which is a kind of summary of all abnormalities that can occur during this acute period, or other phenotypical markers. But indeed, the patient is not a standard patient for 7 days. Of course, his condition can either worsen, the patient can die, or improves, and then the patient leaves the ICU. That's also something that it's important to keep in mind when we look at the data from trials, where the patients in whom we have a long-term outcome are the patients who stay in the ICU for at least 1 week or so. So that's also something important. I also think that it's important to understand that the data from association studies or retrospective studies are just hypothesis generating in any field of medicine, and then you need prospective trials to assess if the hypothesis driven by the retrospective data is true or not. We had a lot of data showing a link between the energy deficit, so the difference between intake and consumption, and complications. When several trialists increased the amount of energy provided to the patient, the prognosis was worsened. So it was exactly the opposite to the expectation, and so the hypothesis was no longer true and was not confirmed by the prospective data. So I think that the beliefs are indeed there, but needs to be addressed and assessed properly in prospective trials.
Yeah. You have a question. So if I can add something to that is, so you touched a bit on as well the P, patient identification. So decades ago we started with every general ICU patient should have this strategy. We were so lucky to have a nutritional strategy, so which we could bring to all our ICUs. Then we thought like, maybe we need a more differentiated approach. Let's identify the malnourished patients. But to be honest, although the nutrition risk assessment is recommended by almost every guideline, it is helpful, it should be done, don't get me wrong, but this does not identify patients that are positively responding to our nutrition intervention. Do you understand that? Yeah, so the nutrition risk assessment is clinically meaningful because it's predictive for worse outcomes. But it does not identify patients that necessarily benefit from a nutrition intervention. And this is problematic. This is disappointing. So because I would expect if I would treat a malnourished patient with a nutritional strategy that the patient benefit from an intervention. So there exists, for example, a postdoc analysis from the effort protein trial. Look into that. Liu et al. Published that. They looked at NRS score, Nutrix score, even sarcopenia, frailty, all of this doesn't help. Yeah, so although we are so excited, oh, let's look at the frail patients. Oh, it's malnourished. Maybe it's a combination of both, but it's not enough. Yeah, so therefore we really have to think like, what then? What do we need more? And one aspect in this area is, for example, we haven't really thought about, these are more really, don't get me wrong, static assessments, like diabetes, malnourished. Yeah, this is not really changing a lot very fast over time. What about the inflammatory response, inflammation? So there exists this Swiss effort trial that, for example, has demonstrated if patients have high CRP levels and if you feed them, that they are harmed by nutrition. Oh, that's a good learning. So if patients are highly inflamed, then I should rather not feed these patients. So, but this does not really resonate with our patient identification, not even in our trials. So therefore, we really have to think like, do we need eventually a patient identification tool to look at the static assessment? Let's do nutrition risk. Why not frailty? Yeah, but then as well, some markers for inflammation. Yeah, and then we come to a point that we have more the dynamic dimension and the static dimension. And we will come to the point we need more dimensions, more holistic approaches. We need you guys, yeah? We need persons. We are not yet there to do it just in an algorithm. So we really need to look at different aspects.
If we think about patient-centered approach, I mean the main phenotypical consequence of a long ICU stay is a muscle loss, with a loss also of functional autonomy, impaired quality of life, inability to work or to have the same life than before. And this, the challenge is to find the time when the patients can rebuild muscles, because the muscle loss is unavoidable during the first few days, but thereafter we have to try to dampen this loss of muscle and try to rebuild muscle when the metabolic situation of the patients allows it. If there is an acute inflammation, of course the patient will no longer benefit from high proteins, but once the inflammation is decreased, it's very likely that the patient would be able again to use proteins to build muscle. So that's really the key point, is to find time when the patient can benefit from the nutrients.
And think about your clinical practice. Patients are deteriorating again. Yeah, sorry, or you have readmissions. What are you doing with these? Yeah, or they have refeeding syndrome. Yeah, so this is hard to bring into a clinical trial, but this is happening. Yeah, so they have again an increase of the SOFA score. Yeah, so they have low phosphate levels. So it's hard, to be fair to the trialists. So it's hard to bring this into a clinical trial. But this results in very heterogeneous data in the end. So we tried to do this so as learning. The current approaches for patient risk identifications seems not to be enough. We tried to overcome this with new approaches, frailty, or to as well differentiate between medical ICU and surgical ICU patients. Super important. Surgical ICU patient has just 2 ICU days. Medical ICU patient has 5-6 on average. Yeah, so this is another approach. But we need really more dynamic markers, like, for example, inflammation. And it's not enough to do it once. Maybe we have to do it more frequently, even daily. I've today learned that our Brazilian colleagues have dietitians like 24 hours on the ICU. Is it really important, sufficient to decide once a day what the patient should get for feeding for 24 hours? So it's a provocative question. I don't think so. Yeah. So maybe we need as well to have dedicated people, and maybe in future, hopefully, AI-based algorithms who are telling us, responding to us, like biomarkers are getting up, the SOFA score is getting up. It's time to decrease feeding again. And here's a problem again for clinical trials. It's wonderful in our area because we are still necessary in the clinical practice, but it's hard to bring this in such big trials which are comparing enteral versus parenteral feeding. Yeah, so from the methodological viewpoint, you would say, okay, Christian, but the patient that is randomized in an enteral group has the same problems by chance as such patients who is in the parenteral feeding group. Yeah, so therefore the problems should be in both groups equally balanced. But these are really still so significant problems so that this leads to heterogeneous results. So therefore it's really hard to interpret current findings.
So Christian, yes, please.
Please.
Have you seen, I mean, in sports or consumer electronics, there's this trend of monitoring CO2-O2 ratio or even acetone levels to monitor the own metabolism, and there's a lot of findings that the metabolism, one, depends a lot like from person to person, but also on the activities or also things like the inflammation or pains and illnesses. Is this something that you also see as a trend in like the studies that are conducted to now, that people use these metabolic insights as additional parameters to analyze?
I can start to answer. Of course, the metabolic rate or the energy and expenditure changes from hour to hour, and so we try to measure while the patient is quiet, without fever if possible, to have a reliable measurement. And the important point is that energy expenditure was believed to be the caloric requirements, which is no longer true. In fact, during the acute phase, the energy expenditure is the maximal rate, the maximal amount of calories that you should give. Even 50 to 70% of the energy expenditure should be the maximal amount of calories that you should give. While during the anabolic phase later, when the patient is always in the ICU or in somewhere else in the ward, that the energy expenditure should be the minimal amount of calories that you should provide to the patient. So the interpretation of these data, of the energy expenditure, changes over time. And that's an important concept to understand. No, basically the assumption is that the 20-minute recording of energy expenditure in quiet conditions is a reflection of the energy expenditure during the 24 hours. Well, that's an assumption. We have nothing better than that. We cannot monitor continuously the patient.
Please.
Thank you. Recently, two important studies was published about amount of protein in critical patient, effort, and precise. What do you think about the methodology and the results? Because, excuse me.
No. Why is this question? Didn't we talk before? No. If I can answer. So, first of all, I think such research takes so many years, efforts, and all of this. Yeah. So therefore, I really appreciate, although I don't like the results. Yeah. I was disappointed. I really appreciate what the investigators have done, and especially effort protein. Over 80 ICUs, a volunteer-driven clinical trial, because all the people around the globe wanted to have an answer about the right protein dose. Yeah, just imagine, like in 2017, guidelines came up which were excited about recommending high dose of protein without really evidence. Yeah, so and therefore, Darren Haaland did really a great job to bring the people together, and the people there themselves even thought, like, I would like to take over a bit of the responsibility, want to be partly a game changer as well, and contribute to the evidence for our patients. Yeah, and without to get monies or maybe a authorship. And this is really something which makes our community unique. First point. Second point is, so we have valuable learnings which we have to take away. So I think at this stage we cannot recommend very high protein doses from the very early beginning in all patients. We need more differentiated approaches. That does not mean protein doesn't work, it's not important. It is important. Yes, it's very, very important. So, of course, otherwise our patients will lose muscle mass and they cannot recover and they will lose, then we really want to attenuate the loss of muscle mass. So therefore it's really, really important. But we need a differentiated approach. I still believe, I cannot really prove that protein is still, as well in the early phase, of high importance than even energy for some reasons, because there might be a positive response mechanism like the flight and run mechanism, so which we know, the endogenous energy production, but there's not an endogenous protein production, which makes sense. But so therefore the relevance seems to be higher, and the learnings are still we have to identify patients and maybe not in the very early phase. Very early means like 3 days, and as the the inflammation does not like to count into days, we have to think about markers again, which are informing us like when is the acute phase over, so that when we can ramp up. I really am not a friend of these modules like day 1 this, day 2 this, and day 3 this. It doesn't help us, So, because we really have to look to the data, SOFA score, CRP, PCT, whatever you have. Look at your patient even, So, if the ventilator settings are getting down, it can help you as well to increase it. And the learning is as well if you have a patient with eventually AKI stage 1, AKI stage 2, be cautious with your protein doses, maybe not too high if the patient is not dialyzed, because you've seen in this post-hoc analysis, so that they are really harmed by a very high protein dose. So therefore, in brief, protein matters. Next sentence is, let's identify the phases of critical illness. And I forgot the third one.
Okay, meanwhile, I can just add a few, 3 short points. First, I think that we understood recently that feeding can be toxic, and macronutrients should be assessed as drugs with risks and benefits, and there are side effects in case of excessive doses of carbohydrates, proteins, lipids. So there is a potential for toxicity, and so that's something that was underappreciated, I think, in the past. That's the first point. Second point, I think that the proteins can be used either as energy substrate or to build muscle. What we want is the proteins to be used more to rebuild muscle, and then we need to add the proteins when the condition of the patients allow the building of muscle, implying so we will avoid an excess of proteins during the acute phase, and also we will avoid an excess of protein when the patient is unable to move. So it should be combined with physical activity, in my opinion, but this needs to be proven in prospective trials, properly designed to address the question with a nice and PICO concept. And so also the protein oxidation is something that we don't need. If the body receives enough of the other macronutrients, there is no need for high protein oxidation. So these are the concepts that were really revealed by these surprising results, which really reflect the divergence between the retrospective data analysis and the prospective data. I think the prospective data are really very interesting, revealing, and of course needs to be included into our clinical routines.
And if I can just add to this timing point, which again and again comes up, if you remember the Teams trial about exercise, we have as well learned like some patients were harmed by very intense exercise. Maybe here the timing and identification matters as well. So maybe we are here in a field as we have to care about the route, the energy, the combination with protein, the timing. It's really complex. So isn't it a bit naive for other interventions that they just start with new drugs, one dose in these patients? So I think we're in a wonderful situation, yeah, so that we think about all the different aspects and we really have to try to bring them together. It's nice for us in the clinical practice because we are still needed, but it's hard to bring it into a clinical trial. Yet we have to take the takeaways from effort protein, precise, about target protein is on the horizon. We expect that this will be published in, I think, mid of June. So you have regarding the combination of exercise and protein, there's still the Nexus trial, which is oncoming, a large-scale RCT. There's a Nutria 4 trial. There's a lot going on as well to try to explore new ways in this area. Yeah, so.
But still, the data are the data. You may not like the data, but these are the data. And it can challenge the beliefs or the dogma or anything, but these are the data. And we should adapt to the data and not the reverse.
And if you talk about that, another point is in the past, experience from smaller single RCTs have been taken up very fast into guidelines. And this is a very unfortunate situation because single center RCTs are very much appreciated, but they overestimate the effect size. Yeah, so like if you see a mortality decrease of like 30%, you should be skeptic about that. Yeah, so, and this happened a lot in the trial. Yeah, so in these times it's recommended that if something is really taken up into guidelines so that you need at least a multi-center RCT or 2 single-center RCTs so that it is really considered. And this is as well something which influenced our field. This is why we are stepping back in many recommendations, because we were very enthusiastic about single-center studies or observational studies which were taken up, and associations are not a proof of concept. Yeah.
And I think that it's also important to remind the importance of the level of evidence behind the guidelines. So I think that when you read a guideline, when you read a recommendation, first read the level of evidence behind and the consensus between experts. Because sometimes you read something which has a very low level of evidence. This means that it's very likely that this recommendation will change within the next years or so. Yeah. While if the aspirin or the beta blockers in acute myocardial infarction is very unlikely to change, as it was proven in large cohorts of patients. So I think the level of evidence is the first thing that you should read before reading the content of the recommendation. Yeah. Having been involved in several boards of recommendations, I can tell you that.
And
certainty.
As we unfortunately come to an end, and the beginning of amazing other talks tomorrow and interactions here. So I think let's take the learnings. Yeah, so it's not all disappointing. Yeah, so we have identified patients which were harmed eventually by our intervention. Yeah, so therefore we know where it's time to proceed with caution. So the enteral route is still what we recommend. We know that it's good, it's preferred over the parenteral route. For example, we want to compensate still micronutrient deficiencies. If we know about that, we know that the timing really matters. We have biomarkers like insulin dose and all of this. And today I was fascinated about the posters of research which we have reviewed and where we were listening to. And I really encourage you, if you're interested, keep on in this area. Yeah, and this is my best advice I have. If you're interested to learn more, to be more involved in that, speak to the people, so they are open before you decide to do it on your own. I think this is maybe one of the most important lessons before you start something, or if you want to do something, speak with the people. They are very friendly, open, and
If I can add an advertisement, so we did a pre-course on metabolic and nutritional issues in the ICU yesterday. We will repeat that next year during EasyCam on the Monday, so it will be Monday, March 16, 2026, so we will be able to listen to other talks, other views, and nice discussions, and also to see a clinical demonstration of the use of devices as well. So this was an advertisement, but I confess.
Any further comments?
We have still 30 seconds left.
So the good message is we are still here after the 90 seconds. All right, thank you for your interest.
Enjoy the Congress. Thank you. And enjoy Brussels.